causes. Cardiovascular disease and cancer has been the leading cause of death for years, right? We have noticed a decrease in the cancer death through the years, but we have noticed an increase in the cardiovascular death on the cancer survivor patients, right? This is what is bringing the importance of the cardiac oncology. We need to create a multidisciplinary team to deliver the integrated and personalized approach on patient care. So this is a new topic. It's a new field in cardiology and also hem-onc, and now it's going to be a new topic in the emergency room that is aimed to reduce the morbidity and mortality and to improve the quality of life of patients surviving cancer. They concentrate in preventing, diagnosis, and treatment in the cardiotoxicity and that result from chemotherapy and radiotherapy, right? It's how we're gonna identify these patients earlier to start the treatment, the prognosis, and the prevention. And if they develop the cardiotoxicity, to identify early to also minimize the deterioration on their cardiac status. The most feared complication of the chemotherapy or radiation is the cardiotoxicity, but it's not the only complication that you're gonna see. So cardio-oncology is, as we talk, is a whole treatment plan, right? The patient gets diagnosed with cancer, they're gonna get the evaluation to re-stratify the cancer to select what is the best treatment. Once they select the treatment for the cancer for breast, if it's gonna be radiotherapy or it's gonna be the chemo, they're also gonna be assessing this patient for the cardiovascular risk, right? They're gonna be assessing these patients with EKGs, cardiac enzymes, pro-BNP, cardiac imaging, and they're gonna stratify the cardiovascular risk, and then they're gonna target the best treatment of the cancer and also how to minimize the potential complications of the treatment in their heart, and also how to identify early to start treatment to minimize those effects also. Once they develop, they're gonna start the cancer treatment and they're gonna do the follow-up that they need for the cardiovascular status. Right, these patients, how you re-stratify, you start like every patient with history and physical, right? They're gonna have the same risk factors that the normal population, in addition to the chemotherapy that we're gonna mention. So they could have, if they could be sedentary, obese, high alcohol intake, they could have the same cardiovascular risk factors of smoking, arterial hypertension, diabetes, high cholesterol, right? Also, they could have already history of myocardial disease, heart failure, valvular disease, arrhythmias, and they could have cardiomyopathy or hypertensive ventricular failure. But now we need to add the risk of cancer treatment, anthracyclines, radiotherapy, right? When we see patients in the emergency room with a chief complaint of chest pain, right, we apply the TIMI score, we apply the heart score, all those, but none of them yet has the cancer as a risk factor, right? And it's not only ongoing cancer, it's also resolution of the cancer because they already received the treatment. Now we should be considering that as a risk factor on these patients. So I mentioned some of the studies that we're gonna be doing, include the EKG, the cardiac enzymes. One of the baseline, you always get a baseline echocardiography, right? What you're gonna be seeing in the emergency room, not all the time we do echoes in the emergency room, but you could compare if the patient comes with chest pain and has history of cancer, previous cancer, and they got treated or resolved, they have, now they have that increase. And if they have a echo done about 3 months ago, and we're gonna talk about that a little bit later, and you notice a decrease in the most recent one and no one is adding those dots together, it could be you identifying the risk of cardiotoxicity. If they have a sudden decrease in the ejection fraction, or the ejection fraction in less than 50, that's highly concerning for cardiotoxicity. Other factor that they're looking is the global longitudinal strain in the left ventricle. The studies have shown that that change of more than 50% is going to be even earlier sign compared to the changes on the echo in the ejection fraction. So if you notice the global longitudinal strain to be increased, that patients should be evaluated by the cardiology early and also in combination with the hematology oncologist. So this is an example of some of the medications that are related to cardiotoxicity. Mainly is the anthracyclines and also the radiotherapy and the HER. Why they cause the cardiotoxicity? Because they have affect the DNA double strand breaks, and also it could cause damage in the mitochondria. Also, the HER causes direct damage to the cardiomyocytes. Some of the examples of the surveillance that they plan with these patients, right? Once you classify this patient as low, moderate, high, and very high risk, mainly the low and moderate is going to be very similar to screening, and the high and very high are going to be also similar in their comparison. So you're going to have a baseline of the troponins and the pro-BNPs, and every 2 cycles for those low and moderate risk, you're going to repeat those studies. That's while they're on the chemotherapy. And this is going to vary with the medication that they're receiving for the chemo or that they receive. That's why it's important that it's a combination with cardiology and also hematology, oncology. For the high risk, it's going to be a baseline, but also they're going to be follow-up with every cycle of the treatment. Now, once they finish the chemotherapy, they're going to be, for the low risk and moderate risk, it's going to be within the 3 months after the treatment that you're going to start the enzymes follow-up, and also 12 months for the echocardiogram. What is going to vary with the high risk and very high risk is that you're going to do the echocardiogram sooner, and also more frequent the enzymes. This is another example with another of the medications that I'm not going to go over, but you see the difference on the surveillance. Other pathologies that you could see with the cardiovascular effects of the chemotherapy and radiation is aortic disease, right? You're gonna get the porcelain aorta. Also, you could have what we mentioned, heart failure and cardiomyopathies. You could have pericarditis and restrictive pericarditis, microvascular disease, valvular disease, rhythm and conduction abnormalities, cardiac ischemia, and arteriosclerosis. So going to also, in addition to the cardiotoxicity, when you see patients that they started the chemotherapy and suddenly they were having normal blood pressure and suddenly they're having elevated of the blood pressure, you need to consider that that could be a reaction due to the chemotherapy. We should not take or tell them that they need to stop the chemo. Many times what they do with those medications that is causing this is to decrease the dose of the chemotherapy until they start getting better, because some of these cases could be reversible. Or they could be started in ACE inhibitors or calcium channel blockers. Right. Also, when these patients present with arrhythmia, that the most common are AFib, and also they could have QT changes. But when you're seeing AFib and they need also anticoagulation, these patients are prone to more complications due to anticoagulation, so the recommendation is to start with the low heparin as much as possible, and if it's needed, then to do a short course of the IV heparin. The patients also could develop valvular disease, as I mentioned before, and these valvular disease complications can take almost 10 years to start presenting, right? And it could go from regurgitation to also, they could present with infective endocarditis. So you need to have a high suspicion in an immunocompromised patient after cancer treatment, and it could take even 10 years because they could be, the valvular presentation could be due to infective endocarditis. So the interdisciplinary approach with including cardiology and hem-onc in these patients that are presenting to your emergency department with chest pain with a previous history of cancer or current history of cancer. This is a more complex graph of what happened after. That is mainly you re-stratify. That is how we see the patient with chest pain in the emergency room and the follow-up that they're getting afterwards. So why is important cardio-oncology in the ED? It's, they have the consensus and also how they make the diagnosis of the cardiotoxicity. As I mentioned before, a change of the decrease in the left ventricular ejection fraction more than 10%, or a global decrease in the ejection fraction less than 50 that they mentioned, that is mainly 40, the goal, and the global longitudinal strain, a reduction of more than 15%. It has a high possibility. So what is important to take a good history in the emergency department, knowing if that patient has history of previous cancer or current treatment. If you notice any sudden change in the blood pressure and this patient, consider that it could be due to a new medication that they're receiving as a chemotherapy and they need to be treated immediately. And also, if you notice some increase in the baseline troponin or BNP, consider that it could be that this patient is going in the cardiotoxicity, and the early detection, the better for these patients. And always involve early cardiologists and oncologists in the ED. Thank you very much.
Any questions from the audience? If no, we'll move to the next. Thank you so much. Next speaker, Dr. Sandeep Sahu, whole blood transfusion in trauma shock, current trends.
It usually doesn't hurt to applaud, so let's do that. Yes, cheers.
Thank you, chairpersons. I am thankful to the organizer from the Turkey, especially Dr. Basar and Beshet, and it's really a privilege to speak in front of Professor Vincent, because a lot of friends from India, and we are listening him for years. So this whole blood transfusion in trauma shock, I'm going to present the current update or trends that is evidence in last 3 years. Namaskar, salam from India, and very thankful to the WASM and APET physicians from the Turkey that you have given opportunity to share us, and it's very nice hospitality that we are enjoying for last 2-3 days. So what is the current status or evidence about whole blood? Whether it's true that old is gold and old wine or whiskey is definitely good as compared to new things, or I am speaking of new things, or it's already a debate is already clear which came first, because definitely here this is not the question here, is because whole blood comes first, then the component comes. And when something comes first, we already have seen maybe our seniors and other colleagues who are senior to us, they have already used this. And what is the current status in trauma? Because in emergency, other condition, there can be things that one patient needed only, like in dengue. Like in India nowadays, a lot of fever, and this is because of now dengue shock syndrome and dengue, and where we have to transfuse platelet and isolated component. But in trauma, that everything is losing. We are losing PRVC, we are losing platelet, we are losing coagulation factor, and we want to definitely give 1, so that we get everything, so that we have a good clot. So the first, as history says, blood transfusion started in 17th, and the blood banking started in 19th, and the hypothesis that all patients need not the component, because not whole blood, they given the concept that as per the patient need, it's good that we give PRVC or cryo or plasma or platelet. But what is the real thing now? Because in trauma, we are talking about 1:1, then we are talking about massive blood transfusion, and we want to have all the coagulation factor, platelet, and a good clot. And good clot needed a component, so you can weigh that the day-night is changing, the time is changing. It's not the day and night different, it's only difference in the rotation. So same thing is here, whole blood is moving full circle. We started from World War I and II, and in these World War, all the military trauma, they have used the whole blood. The things move from 1960s, 70s, 90s, and again, the evidence for last 3, 4, 5 years, 2019 onward, they are saying we should focus on whole blood in trauma. Because one whole blood is not equal to one FFP platelet and PRVC, definitely. When we want higher hemoglobin with little transfusion, when we want higher coagulation factor that is there in whole blood, when we want give less blood volume because it can take one trolley and transfusion-associated problems, the answer is whole blood, because it has everything excess. And only thing is that availability. If human has thought that they want to discover the world, they have done it. So if we reconsider it and we make it available, then we can't compare the whole blood with the component 1:1, because whole blood is better. Definitely there is advantage and disadvantage of both things, but there is advantages of whole blood. And as we are searching literature and we are coming not in medical science, but the social media also, they are saying that one whole blood is not one combination of PRVC, FFP, and platelet. If we are trying to increase or recreate a whole blood, then it is not 1:1. So this proper randomized clinical trial that given us, initially the debate was 1:1 or 1:2, 1:2. So ratio debate is going on from the last 10 years, and ideally whether we are to achieve, especially the developing world. The developed country, I know they have their protocols and SOP, and they were able to do it. Because if we have ratio, then when we had the point of care testing. Because in India, nobody is everywhere. In developed country, they have the developing country, they have the point of care testing to assess the viscoelastic test, that how they can target. So if we say this, the ratio debate 1:1 or 1:2, it does not result in significant difference. So research is emerging that shows that whole blood works better for these in trauma patient as compared to fraction component, and it's a rediscovery, it's not a new discovery. And whole blood versus component therapy in transfusion trauma patients, they're saying that mortality is less because you are transfusing less. Even the cost, because medical science, everything is cost. When you give multiple transfusion, every component has a cost, and also the cost to give it. So whole blood was should with the lower charges and improved logistic, especially when trauma, when we are dealing with massive blood transfusions. This study in 2021, that is a UCENTCOM, that is a US Army, they have done 5-year prospective study and 1,700 patients. Those receive both the component and the whole blood, and they say whole blood use increased significantly with time in last 5 years. And because the supply is also increasing, and without a long-lasting platelet component, that is a problem with the component therapy, because we know that as the components of more than 14 days, this platelet is only working for first week, 3 to 5 days. Another study that whole blood transfusion versus component in adult trauma patient with major hemorrhage. So more than 3,000 patients that is compared in database, and more than 1,800 records, 6 studies. So what this study says, no study reported worse survival with whole blood. However, there is significant evidence to support or reject the use of whole blood transfusion as compared to component therapy in trauma with massive hemorrhage. Another study, whole blood transfusion versus component therapy in trauma resuscitation, a systematic review and meta-analysis, and in 2020, and this says that On this meta-analysis, whole blood transfusion was not assured with 24-hour mortality, the odds ratio as compared to the component therapy, whether it is 24-hour mortality or 30-day mortality. Another study by this Brill Jason, that impact of incorporating whole blood into hemorrhagic shock resuscitation, analysis of 1377 consecutive trauma patients receiving emergency uncrossed blood products, and they say that it has improved survival because odds ratio is saying this. They have decreased need of overall transfusion amounts, 60% less component products needed in whole blood group, and effect of survival are good, especially in severe trauma patients. So this published in JCS, that is American College of Surgeons. And in US, this group, Dr. Brian Cotton, they are working hard for last 5 years, where they say that low titer group O whole blood, LTOW, and they are promoting this, that is remerging role of whole blood. And as we know, this is a walking blood banks. People in military, they have the blood groups, they have a screen, they have already know the blood type, and they are the walking blood banks. So they have the resources, and military is using for Afghanistan, Iraq war, and all the war areas. That is, and we are also, and nowadays we are talking a lot that this country is against this, and things are going on, and it may increase. So whole blood based resuscitation by using cold stored low titer O units, that is also FDA approved now. So this can be used. Only question that it is universal versus type specific blood, RH whole blood versus RH negative blood, or we can use safely in children. The answer is that. Answer is yes. Whole blood resuscitation is safe in pediatric trauma patients. This multicentric study that says that it can be safely used in pediatric trauma patients, 0 to 17 years. And another study is low titer whole blood, truly a universal blood product. This answer is that it appears to be a safe product for universal use across all blood groups. Group B recipient arrives with worse physiological value in shock, and they receive whether this whole blood or component. So another evidence is in 2021 in emerging blood transfusion for trauma patient with perioperative resuscitation standard of care. In 2021, whole blood transfusion is used especially in military scenarios and is also becoming more and more popular in civilian world. Although it is accompanied by a strong lack of evidence, and so we need more things to study and explore so that the God given us.
2 minutes, please.
Yeah. So the God gift can be used properly in saving life. Single institutions trial comparing whole blood versus balanced component. 50 years later, where we are, we saying that whole blood is better, and it has less in-hospital mortality, less ventilator days, and pulmonary edema and all that. A review in transfusion whole blood for trauma patient outcome at higher doses. So they say that we are now moving from 1:1 transfusions to the low titer group O whole blood transfusion, because the additives in the component therapy, they are also not increasing the oxygen carrying capacity, and they dilutes the coagulation factor. So a lot of evidence. So in summary, by reviewing this 3 to 5 year recent evidences, whole blood used many years since its inception, that blood can be transfused in an human for saving lives without any harm. It proven time tested in military trauma. Thousands of patients, hundreds of studies, and evidences also emerging in civilian trauma. Only thing is that everything in life has an advantage and disadvantage and risk. So same here with the component and the whole blood. Only thing that availability. If it is available, definitely, because in my residency in India, we have used this. Now, if it is available, I think most of you would like to use it as per the evidences, both in adult pediatric trauma patients and in civilian setting also. Thank you. Thank you so much.
Thank you very much. That was a very holistic talk, if I may say. Thank you. Any questions at all, or shall we take them in the end? Right.
Okay,
Thank you.
thanks.
Thank you very much. If anyone in the audience has any form of backache, headache, heartache, any of those things, please do not leave this hall. The next talk is on newer analgesic drugs by Dr. Rahul Balasubramanian.
Good afternoon, everyone. First of all, I thank WASM team as well as EPAT team for giving me this opportunity to talk on the topic new analgesic drugs. So, overview of this discussion would be briefly described regarding the pain pathway, the changing landscape in pain management, mainly the CERTA strategy, evolving analgesic and pain ladder, brief description about traditional analgesics, characteristics of new generation analgesic, rather analgesia, and few examples of new analgesics. So you all know pain is the root cause of main presentation, almost 75 to 80% of all complaints according to the present prevalence across the globe. So what are the challenges? Because delayed pain management is a routine in most of the busy ER. And another one is oligoanalgesia. So what do you think? The reason for oligoanalgesia is because of the fear of the side effects or the adverse effects because of the routinely used analgesics. And our aim is not to get a zero pain, but to have a practically reasonably good pain relief on reassessment, reduction of at least 40% of pain score. And in the background of opioid epidemic in all the developing countries, even in developed countries, we have a wide use of opioids, which leads to a scenario called opioid overuse or opioid epidemic and its side effects. So to conclude, or in short, we need to have a balanced analgesia. You all know this pain physiology, the pain pathway, which is by peripheral nervous system as well as central nervous system. Any nociceptive stimuli from periphery goes through the myelinated as well as unmyelinated fibers, reaches the dorsal column of spinal cord, and then to the brain and the higher centers. So as in the diagram, there are different levels of analgesics which can help decrease the pain. That can be both pharmacological as well as non-pharmacological. So my talk would be not only new analgesic drugs, rather analgesia. So it need not be always drugs which can decrease the pain. It can be some other non-pharmacological techniques too. So to review the pain ladder, so the conventional pain ladder, we have 3 steps to start with: mild, then moderate, and severe pain. Usually, we have the conventional drugs. To begin with, the most safest one is acetaminophen, paracetamol, or maybe NSAIDs. Then we move on to weak opioids and strong opioids. So what WHO has come up with is a new addition. In each step, it can be an integrative medicine therapy. And while you leap from step 2 to step 4, we have an additional one, that is minimal invasive intervention. So that can include, which we all know now, even after the advent of the ultrasound and easy availability of ultrasound, regional nerve blocks as well as plain blocks are being used, which can be used in order to get a balanced analgesia so that we can reduce the adverse effects of analgesics being used. So what is the armamentarium? We told that the integrative medicine therapy, which we can include in each and every steps of pain ladder, can be a non-pharmacological, which include physical like physiotherapy, osteopathic manipulation, mechanical support, or active mobilization, direct like heat or ice, acupuncture. All this have got even adequate evidences to use transcutaneous electrical nerve stimulation, deep breathing, and ultrasound. Indirect like music therapy, aromatherapy, hypnosis, and even guided imagery, which can actually decrease the pain. Educational and physiological like cognitive behavioral therapy, which been using for psychiatric patients, verbal suggestions, and family support. So this can be integrated to any step of the pain ladder. So it has come to an extent that a virtual reality helped reducing the pain during labor. So there is a Frey and et al. Showed in 27 unmedicated pregnant female could decrease the pain and anxiety. And in 2018, a systemic review by Scapin et al., which includes 34 studies, showed virtual reality can decrease pain while dressing changes, physical rehabilitation, and physiotherapy. Coming to this, what is CERTA approach? That is nothing new, but we all know what is written on the left-hand side of the table. That is nothing but different targets, the channel, enzymes, receptor targeted analgesia. So rather than shooting blindly, we'll narrow down it and nail it. So that's what the CERTA approach is all about. So according from the history and the pathophysiology or etiology which you know regarding the pain presentations, you can actually target or nail the exact cause. For example, for COX and COX-2 inhibitors, we usually use ibuprofen, diclofenac, naproxen. So you can exactly nail the causative inflammatory markers. So coming to a few drugs which are considered new, need not be a newly invented one, which was used previously for some other indications, now being used as a neuroanalgesic modality. So methoxyfluorine, known as green whistle, it is a halogenated volatile anesthetic. It is non-opioid alternative to morphine that is used for acute pain relief. So usually, when I talked to some of my friends in UK yesterday, so they were telling they use it frequently in pre-hospital scenario when there is some fractures. So now this is being used widely in New Zealand as well as Australia, but it is banned in United States because of the nephrotoxicity, which was there when used in higher doses. So basically it is used with a puff. You can take 3 ml of the methoxyfluorine in a charcoal container and take the puff 1 or 2 times to decrease the pain. And it is marketed in UK as Penthrox. So the take home would be, you can use it, but be careful how many times you use it and how you use it, and be careful about the nephrotoxicity. And there are RCTs on this, like Stop Trial, Mediata. So it's not a new thing, but it's being using, but have to be careful while using methoxyfluorine. Next is dexmedetomidine, which again is not a new drug, but if it can be used intranasally also, which actually decrease the side effects. You all know that the side effect, it being an alpha-2 agonist, it can cause bradycardia and hypotension. So if you can use it intranasally, it can actually decrease the opioid use, which we use usually for post-operative patients. So concomitant dexmedetomidine in post-operative patients is a good option, along with regional blocks as well. Next is buprenorphine, used for treatment of withdrawal. It's an opioid receptor agonist, and it is being successfully used for neuropathic pain, cancer pain, as well as post-operative pain, and even in renal colic. So 4 milligram sublingual buprenorphine is an option for acute bone fractures. Next is a subdissociative dose of ketamine. It's a non-competitive NMDA receptor antagonist, and the main mechanism of action is decreasing the central sensitization and pain memory. And subdissociative doses, 0.1 to 0.4 milligram per kilogram. Again, this can be used intranasally at much lower doses. Early and rapid pain management and long-lasting analgesia is one of the advantage, and it bypasses the first-pass metabolism. So again, it helped in decreasing the side effects. Next is topical clonidine, which is classically used for refractory hypertension, and especially in chronic kidney disease. So this can be used topically for painful diabetic neuropathy, and also being used as a topical agent, again decreases its adverse effects. So this table mainly enumerates few drugs which can be used intranasally, which we already discussed: dexmedetomidine, ketamine, fentanyl. Intranasal fentanyl is there in a lot of pediatric algorithms where you can't get an IV access. You can resort to intranasal fentanyl.
Last 2 minutes, please.
Yeah. Next is intravenous lidocaine, which has been, it can't be used routinely for a renal colic, but refractory to other drugs like diclofenac and opioids, you can consider giving intravenous lidocaine for renal colic too. Desmopressin in renal colic, again, its analgesic effect, it's due to its antidiuretic property. Decrease the renal pelvis pressure, and it is causing decreased pain. Next is tapentadol, a synergistic mu opioid receptor agonist and noradrenaline reuptake inhibitor. Doesn't have an active metabolite, so the risk of accumulating and producing overdose or adverse effect is less, and is metabolized by cytochrome P450 enzyme. So it has got less side effects like nausea and vomiting compared to opioid, but be careful about respiratory depression when you're using it. So alternative to morphine and oxycodone. This remimazolam is not an analgesic as such, but it is used as a sedative, but can cause analgesia when used with other drugs. So this is the CERTA strategy. You can map the particular receptors to the pain presentation, and you can choose which drugs to be given to the patient. It's not a complete comprehensive list, but you need to have the assessment of the patient at the same time to look for any contraindication. So what is the challenges when you talk about a new drug or a new therapy? It is always the cost, the accessibility, as well as the potential side effects. So being said that, these are the challenges, we should work on it, and the future prospect. So we already discussed the pain pathway. The sensitization occur in the dorsal horn of spinal cord and the higher centers of the brain. So the future research or future analgesics which are being developed or are in pipeline is being addressed regarding the central sensitization and long-term potentiation. So take-home point should be limited newer analgesics are introduced recently. So older drugs used for other indications are being used for analgesia. Better we go for a channel enzyme receptor targeted analgesia rather than shooting blind, nailing it down. And there are non-pharmacological options. And finally, reduce doses, thereby optimizing safety and efficacy of analgesic regime. So our aim should not be a zero pain, but a balanced analgesia. So these are the references. Thank you. I'd be happy to take any questions.
Do we have any questions? Is anyone in any kind of pain? Okay, it's good to know. Superb. Thank you. Thank you. The next speaker is the last speaker and is talking about a topic that gives headache to patients and also gives headaches to emergency physicians, because we are seldom good at picking it up. Ladies and gentlemen, last speaker for this session, Dr. Soumya Nair, Management of Acute Glaucoma.
Thank you, Dr. Mutasa, and thank you, Dr. Rahul. Good afternoon, everyone. Am I audible? Yeah. Okay. So I would like to thank World Academic Congress of Emergency Medicine for giving me this opportunity. It's an honor and privilege to be on this stage. My topic for today, I'll just quickly introduce myself. I'm Dr. Soumya, Assistant Professor of Ophthalmology, Kasturba Medical College, Manipal Academy of Medical Sciences, Higher Education, Manipal, India. slide change. Yeah, good. So the topic of interest today is emergency management of acute glaucoma. Let me start with a clinical scenario. A 60-year-old female presented to the ED with complaints of acute onset diminution of vision in the right eye, which is painful, and was associated with severe headache and recurrent bouts of vomiting. She had other associated symptoms like redness, photophobia, and lacrimation. So what are the possible differentials you can think of? The first possible and the most important differential in this situation will be primary angle closure glaucoma. But you have to keep in mind other causes of acute glaucoma like traumatic, inflammatory glaucoma, lens-induced glaucoma, and drug-induced glaucoma. So what is the importance of primary angle closure? Primary angle closure glaucoma is a sight-threatening condition. As an acute care physician, saving the sight is one of your priorities, isn't it? And acute angle closure glaucoma is a great mimic too. It can mimic many of the emergencies that come into your ED, like neurosurgical emergencies, gastrointestinal emergencies, and tox emergencies. So how can you evaluate such a patient when he or she comes into the ED? So we can start with simple bedside evaluation of anterior segment, anterior chamber depth evaluation, and digital tonometry or applanation tonometry if there is a slit lamp in the ED. The anterior chamber depth evaluation can be done using a simple torchlight. Ask the patient to look straight, shine the light from the temporal side of the patient and look at the anterior chamber. Two things you have to look for. Is the anterior chamber well illuminated? And second, is the nasal iris of the patient seen properly? If the nasal iris is not seen properly and the nasal anterior chamber is in shadow, that indicates that the patient is having a shallow anterior chamber, just like the second picture there. Now, how can you assess the intraocular pressure bedside in the ED? A simple method called digital tonometry will help you. With the index finger, press on the upper lid on the eyeball of the patient, ask the patient to look down and feel the pulsation on the other index finger. And if the pulsations are not felt and the eye appear rock hard, that means the intraocular pressure is very high. Now, is there a role for point of care ultrasound in case of acute angle closure glaucoma? Yes, there is. Why? Because often in cases of acute angle closure attacks, the patient will be having a cloudy cornea due to corneal edema. This will impair the visualization of the anterior chamber and the depth assessment. In such cases, we can rely on focus. So, we can assess the anterior chamber depth, the anterior chamber structures. Even we can look into other causes of acute glaucoma like phacolysis, phacomorphic, subluxation, hyphema, etc. Now, while doing focus of the eye, we have to use a linear probe, a high frequency linear probe, and it has to be kept transversely over the closed eyelid of the patient after applying a lubricant, and the pointer should be towards the temporal side of the patient. And we can see the whole globe, then the cornea. The anechoic area beneath the cornea is the anterior chamber, and then the anechoic area beneath the anterior chamber, this is the anterior chamber, and this is the lens, which is the anechoic area beneath the anterior chamber. And the line between these two anechoic area is the iris. And the large anechoic area beneath the lens area is the vitreous cavity. Now, coming to anterior chamber depth assessment, in the first image you can see that the anterior chamber is very deep and the angles are wide open. While in the second picture, the anterior chamber seems shallow and the angle seems narrower. Now, this image, the first image, shows the pupillary block. The iris is opposed to the lens at the pupil, and there is an iris bombe which is causing complete closure of the angle. The second image, you can see an anechoic lens, and above the anechoic lens in the anterior chamber, there are hyperechoic areas, which is suggestive of a hyphema. We can also evaluate lens changes using POCUS. In the first picture, as you can see, the lens appears hyperechoic and bulging forwards, which is pushing the iris diaphragm forwards, shallowing the anterior chamber. This is suggestive of a phacomorphic glaucoma. While in the second image, I hope you can make out that the lens in one area is pushing upwards or subluxated anteriorly, and it is pushing the iris in that area only, causing a shallowing in that area, shallowing of the anterior chamber in that area. Now, coming to the treatment of acute angle closure glaucoma in the emergency department, what can we do? So, the first and foremost priority is to bring down the intraocular pressure immediately. As long as the IOP remains high, the more damage to the retinal nerve fiber layers happen, and irreversible visual damage will occur. So we have to prevent that. The drug of choice is always hyperosmotic agent mannitol. We can give 20% mannitol 100 ml IV over 30 minutes. Also add on IV antiemetic medication and stabilize the patient. Once the patient is stabilized, we can switch to oral anti-glaucoma medication such as acetazolamide, oral hyperosmotic such as sorbitrate or glycerol. When the patient is in the ED, avoid prone positioning because it will exacerbate the angle closure. Also, if there is a traumatic patient with hyphema, advise head and proper positioning. Avoid mydriatic cycloplegic medication, which will also worsen the angle closure. And in certain cases, we have to have a high index of suspicion for drug-induced angle closure as well. So my take-home message from this session would be, if a patient walks into your ED with headache, take a second to look into the eye of the patient. Clinically evaluate the patient in the ED and judicious use of POCUS if there is a suspicion of angle closure glaucoma. And immediate reduction of intraocular pressure should be done to prevent irreversible damage to the vision of the patient. So, say this lady walks into your ED. I hope you will keep these points in mind and you will be able to pick up the angle closure attack and manage to bring down the IOP at the earliest, so that the patient won't have a scotoma but will have a clear, good vision and a good quality of life in the future. I'll be happy to take questions. Thank you.
I think that was an eye-opening talk. Does anyone have any questions?
Yes.
I see some redness of eye in the audience. Where is that? Sorry, there. Yeah.
Yeah. Yeah, the digital tonometry. Yeah, it's a very simple test. Ask the patient to look down. Use the pulp of your 2 index fingers. Okay? Place the fingers above the tarsal plate, at the edge of the tarsal plate. Press with 1 finger so that you can feel the pulsation on the other finger. You can feel it on your eyes itself, can't you? So that is indicative of a normal intraocular pressure. Normal. If it is very high, the eye will appear rock hard and you won't be able to do these pulsations. Okay? Is that clear?
Yeah.
Thank you.
After this talk, you can meet her. She'll do a free examination for you.
I'll be happy to. Yeah. Any more questions? Okay. Thank you.
There's one more, sorry. There's one more from...
Thank you. I have a question,
Yes.
actually. The setup in your hospital, is it based on ophthalmology present in the ED or emergency physician providing the care for acute glaucoma?
Acute glaucoma, both actually. When the patient walks in, emergency physician can start the IV monitor, but of course, ophthalmology team will be, the ophthalmology team will be notified and they will be taking over the patient at the earliest. Yes.
In-house or home?
Yes, sir.
The ophthalmologist will be in-house in the ED, or he will be called to come. So time is a factor here.
Yes, yes.
So what is actually the time factors that will require for ophthalmologist to be in-house to provide the care for this patient?
Yeah, so it will take at least 10 minutes for the ophthalmologist on duty to come, but we can save that time also if, you know, if we are trained to look into the eye and understand that this is an angle closure attack, then no need to wait for the ophthalmologist to reach. We can, you know, that much amount of time can cause that much amount of damage to the retinal nerve fiber layer. So that can be prevented. Yes.
Okay. Thank you. Does anyone have any questions for the first two speakers? We rushed them because of keeping interest of time in mind. Any questions for emergency transfusion in pregnant trauma patients? Dr. Indulata is still here. In pregnant trauma patients, emergency transfusions. Any questions on whole blood transfusion?
Yes.
The question on whole blood transfusion. So, Dr. Sandeep Sahu is here.
Yeah, if it's okay, Dr. Sandeep, I have a question regarding actually your protocol. You said in your hospital you do have whole blood transfusion. So what is the setup and how this impacts on massive transfusion protocols?
It's around 18 years back in India when I was doing residency. At my hospital that time we don't have the component therapy. So we are using the whole blood for gunshot and all the laparotomies. But nowadays, in other emergency, definitely emergency medicine, we have component therapy nowadays. But I am especially being my primary specialty in anesthesia, and I am seeing day and night massive blood transfusion and severe hemorrhagic shock in the ORs and ICU. And anyhow, I am thankful to my transfusion department, transfusion medicine department. We have to take component, but we have to do massive transfusions. And after all that thing, the only problem that I have, that patient need go in overload. So, and it's again rethinking with the evidences, because I have given task to what is the recent trends. So recent trend is coming back, and even in the wars, that is Afghanistan and Iran war, and even the things are going in disaster worldwide, the blood bank is not available, Dr. Althani, everywhere. And I think if we got the opportunity to have this whole blood, I would like to use, because I have used this during my residency days. So I have that not hesitancy, and you can say the new thing to use, whether it will work and will not work. So sorry, but nowadays in my hospital we are not having whole blood. But definitely I would like to have, especially it's good for severe polytrauma and hemorrhagic shock. Thank you, Dr. Althani. So what's your say, sir? Because you are a trauma surgeon, I know, and you work in ED, and we have seen your hospital. So what's your thought? I would like to add on this.
We've got about 1.5 minutes, so it's not bad.
Thank you. Regarding actually whole blood, the resistance comes usually from the blood bank and hematology. And in our setting, we managed to have whole blood, but that actually has two side to it. One, you have to have availability of point of care. So in the trauma setting, we have point of care for all actually the point of care required. So we have TAG, ROTAM, INR within the trauma recess in our setting. We have a fridge also, which we have one shipment of massive transfusion plus whole blood sitting in the fridge in the recess. In the OR, we have also a fridge which is connected to the blood bank, and we have this whole setup. The issue is the algorithm that required to run these protocols. And we are actually cautious in these patients because they have, to be taken in consideration their reaction in the future and so on. But we currently have it, and we are discussing this on a regular basis with also a pre-hospital setting possible to have whole blood for this patient. Thank you.
Ladies and gentlemen, just like many commercial flights, we have landed our session 8 minutes before time. So I'd like Dr. Behshat, if he's got anything to say in conclusion. Okay, I think the conclusion is this is concluded. Thank you very much. Thank you.
Please.
Thank you very, very much indeed for your kind invitation again to this World Congress, and many thanks for these very kind words that certainly please me and honor me very much. I like to speak about one of my favorite topics, sepsis, a terrible problem. And you know that we define it, we have always defined it as a bad infection, as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. That's what it is. For a scientific publication, one could use a score to determine the severity of organ dysfunction. But for our everyday practice, we don't need any score. And that's the same in children. So if you look at the pyramid of severity, starting from colonization, an infection will be characterized by some host response, usually fever, an abnormal white blood cell count. When it is sepsis, there is more. There is organ dysfunction. And if there is septic shock, there is an alteration in tissue perfusion and an increase in blood lactate levels, typically above 2 milliequivalents per liter. So sometimes we identify sepsis in a patient having an infection complicated by organ dysfunction. But we must keep in mind, and this is very true in the emergency department, that sometimes patients come with some degree of organ dysfunction and it's not so clear why they have it. It may be sepsis. There may be a severe infection. And when we speak about organ dysfunction, we need to consider 6 organs: the circulatory, respiratory, renal, neurological, hepatic, hematological. And these are the 6 items included in the SOFA score to evaluate organ dysfunction. But I'll focus on management this afternoon, and I will look at the 3 components: infection control, hemodynamic stabilization, and modulation of the host response. So, if you think that antibiotics work, then we should start antibiotic therapy without delay. And we should give the right antibiotic, right? That is particularly important in severe cases, that is in septic shock. So the timing is an issue. We should not waste time when the situation is severe. So if I go back to my pyramid, it's particularly true in septic shock, when there is an alteration in tissue perfusion. And we know that sometimes we waste a little bit of time in the administration of antibiotic therapy. This is a nice recent study emphasizing at the bottom of the slide that this is particularly true in patients with septic shock. Now, hopefully, when there are signs of infection, the antibiotic administration is usually relatively rapid. So you can see when there is hypotension or when there is fever. But still, sometimes we waste time. Sometimes in the administration of antibiotics, we order the antibiotics, but the nurse is very busy with other things, and the antibiotic administration is delayed. So it's not only in the hands of doctors, it is in the hands of the team. Some people may say that we sometimes overuse the antibiotics. In the United States in particular, where there may be some medical legal aspects, give antibiotics to all patients with fever right away. That could facilitate the development of resistant organisms. So today we look at this like this, as disease severity versus degree of certainty. So if we are not so sure about septic shock, but if it's septic shock, the severity is there, we should not hesitate too much before giving antibiotics. But if it's not too bad, we may have time for additional tests if it's not septic shock. Remember these important studies showing that sometimes we admit patients in the intensive care unit for likely sepsis, but actually this is doubtful at the end. When we have all the elements, we may think, after all, it was not septic shock. Or here in an emergency department in Boston, they found the same thing. Sometimes we think it's septic shock, but it's not. It may be cardiogenic pulmonary edema. It may be a drug effect. It may be some malignancy. So sometimes we give antibiotics for some patients who may not need them. We must accept it. But the choice is important too. I like this paper published recently, where they showed that if you don't give the right antibiotic, prognosis is worse than if you give the right antibiotics. Okay. But this is very interesting. If you give wide spectrum antibiotics to patients who do not need it, the outcome may be worse. Perhaps because there is a selection of resistant organisms. So the message is, too narrow spectrum may be harmful, but too wide spectrum may also be harmful for the patient. And we should never forget that the antibiotic administration can be reassessed later. So give antibiotics as soon as possible. The more severe the presentation, the more urgent the antibiotic administration. And antibiotic therapy should cover all likely pathogens, not less, but not more. And of course, source control is very important. And here also, we need to motivate the team. The nurses, the surgeons, if there is a need for laparotomy, for instance, the radiologists before that, the anesthesiologist, a team effort. But let's move to the hemodynamic management. My mentor, my teacher, was Dr. Weil in Los Angeles. And Dr. Weil was saying every patient is a VIP. Ventilate, infuse, pump. Ventilate, well, we have good ways to use non-invasive mechanical ventilation today. But in shock, we should not wait too long before endotracheal intubation if required. If we wait for too long, there may be respiratory arrest. So what are the things to look at? With my colleagues at the Surviving Sepsis Campaign guidelines, I said we need to give recommendations to the doctor about when to intubate a trachea. And they said, oh, Jean-Louis, there is no randomized controlled trial on this. I know, but we need to give some guidance. So would it be the degree of hypoxemia, the neurological status, sometimes the PCO2, the hemodynamic status, the muscle function? Are there plans for major surgery? It could be a combination of those. We need to help the doctors. So my recommendation, actually it's not mine, I found it on internet, it is to ask the patient to pronounce metoprolol. If the patient cannot pronounce metoprolol, it's the right time to put the tube in the trachea. Infuse. Every patient with sepsis will need fluids. Not too much, but not too little. Not too little. And we cannot go by formula. Because a patient with pneumonia may require less fluids than a patient with peritonitis. There may be a little bit of vasodilation or much vasodilation. There may be more capillary leak with unavoidable edema formation. And we may need to bring cardiac output to a supranormal level to bring enough oxygen to the cells. So some years ago, a couple of years ago, people were discussing restricted liberal fluid administration. This is over because these trials randomizing patients for more or less fluids showed no difference in outcome, because some patients may benefit from one strategy, but some others may be harmed, and vice versa in the other group. Look at this recent paper published this year in the New England Journal of Medicine, comparing more fluids with less fluids but more vasopressors. Well, if anything, the patients who were in a restrictive fluid therapy were worse than the others. They were more likely to need a stay in the intensive care unit. Clearly, fluid restriction is dangerous. There will be some edema formation. We don't like it, I agree. But that's the price to pay to have a sufficient cardiac output. We may need vasopressors, I will go to that in just a moment. But vasoconstriction is really to avoid. So we need to navigate between the two. We all know that. Maybe artificial intelligence will help us in the future to decide whether we should give more fluids or more vasopressors. But to stay with simple things. An edematous patient may be hypovolemic. Sometimes there is a doctor coming and saying, oh, there is some edema here. Oh, stop giving fluids. That doesn't make sense. No, we don't know. Because in sepsis, there is always some edema formation. So let's be careful about the word fluid overload. Because sometimes we say the patient is in fluid overload when there is edema. But edema does not exclude hypovolemia, especially if there is hypoalbuminemia, which is associated. So let's be careful. Likewise, the fluid balance doesn't help very much. The patient may still need fluids even when the fluid balance is positive. So we all agree now that we need individualized therapy. Initially, in the salvage phase, when the patient arrives in the emergency department, we could just pour fluids initially, and we try to bring a monitoring system at the same time. You cannot do without a monitoring system. The studies in Zambia or in countries where they couldn't get any monitoring system failed. But hopefully today we have echocardiography that could help, at least initially. We don't need to be experts in echocardiography. In every single emergency department, there must be an echography machine available, not only for a septic shock, but also for trauma, for heart failure, for other problems. So that helps us to go into the optimization phase, where any single variable taken alone will never tell us if the patient needs fluids or not. We actually need to combine variables. We need a dynamic approach. In the operating room, when the patient is anesthetized, we could look at the effects of mechanical ventilation on the blood pressure tracing, on the pulse pressure variation over time. That would indicate that the patient is still responding to fluids. But in the emergency department, no, because we want to avoid sedative agents in shock. Sedative agents today are better avoided because they can decrease vascular tone, decrease the myocardial contractility, increase the risk of delirium, and they induce long-term weaknesses. So today we try the ECASH concept. We try to explain to the patient what's going on when we can. Of course, we control pain with analgesia, but the patient may not need sedation. And of course, the basis for our evaluation of the response to fluid remains the fluid challenge, where we look at an improvement in tissue perfusion and the risk of edema formation. This is based on the Frank-Starling relationship. Every patient is represented by one of these dots and is on one of these lines. So we need to give a bit of fluids and see if cardiac output increases or not. And if we want to assess the risk, we want to have a central venous pressure measurement. Oh, that's invasive! I know, but the central venous catheter can also help to have access to the central venous oxygen saturation, SVO2. It can also help to give fluids quickly. It can also help to give vasopressors safely. Oh, vasopressors can be given by an intravenous peripheral line. Yeah. But one single complication would be terrible. So, the fluid challenge is not the fluid loading, right? It is a technique in which we give a bit of fluids and we assess the patient's response. Sometimes people do it over a too long period of time. I'll try to give fluid for half an hour. That's much too long, because so many things could happen in half an hour. And in the emergency department, the patient may have to go to the X-ray for a CT scan, and we lose that information. So it's 5–10 minutes. In the operating room, it will be 1 minute, because so many things happen in the operating room. But if we return to the emergency department, the studies have shown that giving about 200–250 cc's in 5–10 minutes is sufficient. So give 200 cc's in 5–10 minutes. If the patient seems to respond, seems to benefit, you repeat it. And during these 5–10 minutes, if you want to assess the patient's response, you should not do anything. Don't touch the patient for 5–10 minutes. What shall we check? Heart rate? Well, maybe, but it's not perfect. The blood pressure, not really, because the patients in septic shock may respond to fluids by an increase in cardiac output, and yet the blood pressure may not increase much because there is decreased vascular tone. We showed it many years ago. So optimally, we should actually assess cardiac output and see if cardiac output increases with fluids or not. We could use the technique we like. We just reviewed it for critical care medicine, if you like to look at the various systems available. But again, if you are good in echo, you could just use the velocity time integral to reflect cardiac output, stroke volume, and thus cardiac output. Today, it can even be done automatically. There are some softwares available now that can measure it for you. So that's the fluid challenge technique. You can go to that publication if you want to see the graph. It's quite easy, but we need to pay attention to some simple elements. And the most important one is that if the patient does not benefit, we stop giving fluids. The fluid challenge does not encourage to give more fluids. It does encourage to stop giving fluids when the patient does not benefit. Internal fluid challenge can be obtained by passive leg raising, but it's a bit more difficult to do actually, because the changes in cardiac output will be very transient and very mild. If you like, we did a neat chat, you can find it on internet, with Dr. Monet, who is a world expert in this, asking him, how do you do this? But to go back to simple things, ChatGPT says, the goal of fluid resuscitation in sepsis is to restore perfusion to vital organs and tissues and to prevent organ failure. The appropriate amount of fluids will depend on the individual needs of the person with sepsis and should be determined by a healthcare provider. It is important to monitor the person's vital signs and response to treatment. And it's only then, when the patient is stabilized, that we can think at the stabilization phase and the de-escalation phase with diuretics, with ultrafiltration, if the patient does not have urine output. If you like, we just reviewed it in this paper, the various phases: salvage, optimization, stabilization, de-escalation. Very important to look at which phase we are in. Very briefly, there was a discussion until recently about the type of fluids, the amount of chloride we could put in the IV fluid. That was a question which was overstated. Because we know that saline solutions include a lot of chloride. We know that during surgery, the chloride levels will increase after 2 hours if you give only saline. We know balanced solutions include other electrolytes than chloride, and hyperchloremia cannot be good. Any abnormality is associated with a worse outcome. It has been known for many years that hyperchloremia is not good for the kidneys. So I don't know why we need to do prospective randomized trials with saline versus, if there is hyperchloremia, there is more renal dysfunction. But we knew it from the beginning. So we said it's not even ethical to allow hyperchloremia to develop in some patients. Oh, so we should no longer use saline solutions? I didn't say that. I said we need to monitor chloride. Look at that, 112 as a mean value in these prospective randomized controlled trials. More major adverse kidney events. This was expected. So is it so difficult to look at chloride levels? And if they are, let's say, above 110, if it's a neurological patient, we should not give Ringer's lactate solutions, which are somewhat hypotonic, very bad for the damaged brain. But otherwise, Ringer's lactate solution would be a valuable one. And there may be a place for some albumin as well, some colloids, when the patient has lots of edema associated with hypoalbuminemia. But let's move on. Let's emphasize that severe hypotension must be treated right away, because it's too bad to be severely hypotensive. So don't wait for the response to fluids. If hypotension is severe, we need to give vasopressors right away. Studies of large databases have shown that severe hypotension for 1 hour or 2 may be very harmful for the patient. In this, there have been several studies on this, also on renal function. We could even perhaps propose the administration of vasopressors in the ambulance before getting to the hospital. So VIP, the 3 elements, must be managed concurrently. And we know noradrenaline is the first agent of choice. Adrenaline should not be a first agent. This is a small study, quite old now, showing that the trend is going in the wrong direction. Mortality is somewhat going up when you go for adrenaline. And if you go at the target, we usually say that it's 65 as a mean value. But this is a mean value initially. The trials where they randomized patients for a higher or lower target, of course, showed no difference in mortality. But look at the targets, it was even 75 versus 85. Oh ho, oh ho. That's how it is. When we target the blood pressure, we tend to overshoot. And yet, in patients with chronic hypertension, 75 was not sufficient. So let's go to a higher mean arterial pressure, right? Well, in some patients, maybe. But then you have this other trial where they allowed in patients to be below 65, and there was no difference in mortality. So does blood pressure not matter? Of course it matters, but we need individualization. That's physiology, autoregulation of blood flow to the organs, well known. Now, the most recent recommendations of the Surviving Sepsis campaign rightly state we recommend an initial mean arterial pressure of 65. That's correct. But what thereafter? What should we do thereafter? And people drop the word initial. In our previous guidelines, we wrote, if initiated, vasopressor dosing should be titrated to an endpoint reflecting perfusion. And this sentence disappeared, unfortunately, in the most recent guidelines. So we said in this paper, wait a minute, we need to individualize this. We need to look at the patient. We cannot assume that one single blood pressure level will be good for all patients. Let's look at diuresis, consciousness, skin perfusion. That's what we call the noradrenaline challenge. With vasopressors, we need to be very careful about the risks of vasoconstriction. It's easy to increase blood pressure. We have a number of agents to do that. But the problem is when we increase vascular tone, cardiac output may go down. And that's actually the main reason why noradrenaline is our agent of choice. Because it has a little bit of inotropic effect. It can maintain cardiac output to some extent. There is a lesser risk of decrease in cardiac output. Because if there is a low blood flow, then vasoconstriction can become very harmful. The vasopressor therapy could harm. Maybe good to look at the diastolic blood pressure. If it's very low, maybe there is less risks than when the diastolic pressure is already high. And of course, we can look at peripheral perfusion. We can look at skin perfusion, because there are other options if the patient is vasoconstricted. We could look at it by the capillary refill time. I'm not sure we need to spend much time on this, but let's examine the extremities of the fingers. We may not need a particular device for this. In the past, we were measuring the toe temperature with Dr. Weil. Now, with our team, we look at laser Doppler to evaluate peripheral perfusion. The point is that if the patient is too vasoconstricted, it may be hypovolemia, it may be a poor myocardial function. We can look at it by echo. We can look at it by measurement of central venous oxygen saturation. Remember, in the emergency department of Detroit in the US, Dr. Rivers showed that when the SCVO2 is low, we could give more fluid, transfusion, or dobutamine. And this action may result in lower mortality rate. 3 studies subsequently were negative. They could not confirm it, but the patients were already resuscitated. They didn't have a low SVO2. So the point is that when SVO2 is low, it could be good to do something else to increase oxygen delivery to the tissues. Fluid, dobutamine, perhaps a transfusion. We can even look at the veno-arterial PCO2 gap, but the time is running. I will skip these slides. You could read it. This is our paper in chest showing that if the patient does not improve quickly, we could actually find valuable therapeutic interventions to increase flow. Patient says tachycardia. pacemaker, no. We cannot afford vasodilating agents in patients who are already vasodilated naturally. So it's either fluids or inotropic agents. That's the dobutamine challenge. We could give a little bit of dobutamine in addition to the noradrenaline to try to improve blood flow to the periphery, and this is quite safe in septic shock. We have known it for many, many years. Oh, dobutamine induces tachycardia. Yes, it does. Because any inotropic agent that we know will increase heart rate if it increases the myocardial contractility. Wait a minute. Tachycardia may be bad. Perhaps in some patients we should use beta blockade in septic shock. What do you think? Well, you could find this paper from Dr. Morelli and collaborators 10 years ago now, with very surprising results. A reduction in mortality rate with beta-blocking agents. But the control group has a mortality rate of 80%. 80% in the control group. So we and others wrote letters saying, you know, no. Last week, in the latest issue of the JAMA, you can find this paper where they used the same approach and they had to stop because it was harmful. But wait a minute, they looked only at heart rate, nothing else? I actually went to the microphone and I said, you know, this is unacceptable. Okay, it's published, okay, it's randomized, controlled. But when you have a tachycardia in your patient, you need to think at why this heart rate is fast. And if it's because the stroke volume is too low, because there is hypovolemia, cardiac pump problem, or maybe an obstruction, giving a beta-blocking agent may be very, very harmful. It's only when you have a supranormal cardiac output that you could do that. That's individualized medicine. So that's something of importance. We spoke about transfusions earlier on, and there may be a place for blood transfusions in patients who do not improve, but my time is really, now I'm reaching the end. Lactate levels in the emergency department, yes, of course. It's not a sepsis marker, no. It's a marker of altered tissue perfusion. Any form of shock will be associated with a high lactate level, typically above 2 milliequivalents per liter. And we can now measure it everywhere in the world. If you cannot do it, go to your hospital manager and say that in Antalya they said we need to have a lactate analyzer. And we could repeat the measurements. After 1 hour, the changes in lactate levels are relatively slow. But the idea is that we would like to see the lactate levels going down with time, not going up. Can it guide therapy? Well, it depends what you mean by guide. It helps to tell us whether we are in the right direction or not. But that's all. We should not wait for the next lactate level to decide what to do. Lactate levels change slowly. I will skip the part on vasopressin, which is not another vasopressor agent. We don't know really when to use it, but it's hormone therapy. Vasopressin is a hormone, right? So there are some interesting effects, limiting edema formation, helping the kidney. So there are some arguments to give low doses of vasopressin early on in septic shock, early on. But we must make sure that cardiac output is normal or high. Once again, beware of vasoconstriction. So maybe if you are sure that cardiac output is not significantly reduced, you use small doses, especially if you are concerned about kidney function, especially if you are concerned about edema formation. Hopefully the doses are fixed. We should not really titrate the doses. Angiotensin II is also coming up. Maybe it will have some beneficial effects on the kidney, but it's very costly. It costs about 1,000 euros a day. So we need to have more evidence for this. Last minute, hydrocortisone. Should we give it already in the emergency department? Rarely. Only if shock is very, very severe. We have one study from Australia showing no improvement in survival, but we don't know much about the patients. Many patients were not in septic shock. We don't know the lactate levels, we don't know the degree of organ dysfunction. And we have a study from France showing that in patients who have severe septic shock with a high lactate level, multiple organ failure, yes, corticosteroids can decrease mortality. So if you put the two studies together, you can see a benefit in the sickest patients, in the patient with the more severe form of septic shock. That's where we are now. We should find some better biomarkers. Right now, it's only the severity. So at the end, fluids, vasopressors, inotropic agents if we fear that the cardiac function is altered. Let's look at skin perfusion, urine output, mental status, the three windows of acute circulatory failure, respecting the four phases: salvage, optimization, stabilization, and then de-escalation. And for this, it's quite a bit to do. Infection control, hemodynamic stabilization, modulation of the sepsis response. In trauma, we have a trauma team, right? With a trauma leader giving orders here and there. There is the captain giving orders. There are many things to be done. Insert catheters, call the surgeon, call the radiologist, etc. But in sepsis, it's the same thing. We also need the 5 tubes, the diagnostic techniques, the blood tests, microbiology, monitoring, noradrenaline, other agents, antibiotics. Yeah, antibiotics. Don't forget the antibiotics. Oh, there are so many things to be done. I agree. That's why we need sepsis team at 3 o'clock in the morning as well as at 11 in the morning. In our emergency rooms, we need to have teams taking care of these patients for whom time is essential. When every minute counts, it's the same team perhaps for sepsis and trauma and myocardial infarction. Okay, but we need to have these people ready 24 hours a day, thinking at these 3 parts of the sepsis management that must be conducted together. And that's how we can save our patients with this terrible problem of sepsis. Thank you very much.
Thank you so much, Mr. Vincent. And first of all, I want to say I want to revise my sepsis information after following this presentation. So maybe some of our friends needs to ask you some questions. Dear audience, Could you please ask? Okay, could you please? This is,
Dear Professor, thank you very much for this great and wonderful and excellent presentation. You explained and summarized the topic in a very short way, and you made me to love this topic. Thank you very much. I'm very grateful about it. My question is about that. I listened to you 10 years ago or 12 years ago. If I listened to you 20 years ago in 2020, probably, perhaps, I may listen different thing. So it seems that in recent years there are so many changes. My question is that, 20 years later, what kind of change do you expect to be done 20 years later? Thank you very much.
Ooh, thank you very much for this question, which is an excellent one, but it's another talk. If you give me another 40 minutes, I can discuss it. But, you know, I think that we would like to be less invasive, but at the same time, we want to be accurate. So at least for some years to come, we will continue to be invasive. The arterial catheter, the central venous catheter will continue to use it for a while, but maybe not in 10 years or 15 years from now. Echocardiography will be automated, as I say it, with AI programs, with artificial intelligence programs. We will see the heart on the screen and the variables being displayed on the screen, and that will help us to treat the patient in a better way. We will have better methods to identify the microorganism more rapidly, and this will help to orient the antibiotic therapy from the very beginning. And even sepsis itself will be better identified by biomarkers. We already have the C-reactive protein, the CRP. We already have the procalcitonin, the PCT. I think what we will do is first to bring other biomarkers, but also to combine them so that we will have a more accurate recognition of sepsis in our patients. I believe that we will have a better understanding of the type of fluids to be given, in particular when to give albumin, when to give red blood cells. Because right now we are in an era where we say, no transfusion, no. But, you know, if the patient has alteration in perfusion, the cells need oxygen. And oxygen is provided by the red blood cells. You cannot change it. So that will be another development. And of course, there will be many developments in surgery, radiology, better antibiotics or newer antibiotics, etc. We will benefit from the progress made in other fields. And above all of this, artificial intelligence or augmented intelligence, AI, in any case, AI will help us to better identify the problem and better treat it. We will remain in charge. We will not be replaced by an AI system, but the AI system will provide a very effective help to the team. I'll stop here.
thank you so much. Please, could you please bring the microphone here, the second line here.
Prabhat Nanekar from Amsterdam. Thank you very much for this inspiring talk. But I just wonder, most of the patient who comes with systemic infection does not end up at the ICU. They stay at the ED and go to normal wards. And in the Western world, at least, the sepsis is a disease of the elderly. They have no fever, they have hypothermia, they have no tachycardia, they have normal blood pressure, they have no low pulse rates and all that. This aggressive approach, do you think we should adopt our protocols to the elderly? Because that's going to be the problem. Sepsis is a disease of the elderly, I think, and it will get more and more and more. I just wonder what you think about that.
Yeah, it's a very important question, absolutely. But it leads us into the ethics, because what you imply, to some degree at least, is that we may have some therapeutic limitations in some of these elderly patients, so that we don't want to admit them in the ICU. But the treatment may be much less effective on the ward than in the intensive care unit. You know, if you want to do everything you can for the patient, you need to admit this patient in the ICU. And there is always beds available in an ICU, always. You may have to make difficult choices, as we had during COVID-19. We may have to say, no, I will not take this patient, but I will take that patient, what they call triage. It's a terrible word, but that's what it is. So we could have triage, but if we want to treat a patient with sepsis effectively, we need to bring this patient in the ICU. Now, there are some patients for whom we say, okay, we'll just give antibiotics and that's it. Or at the middle, we could have patients for whom we do what we call the ICU tests. We are the ones who proposed the ICU test about 20 years ago. That's a test in which we admit the patient in the ICU for a limited period of time, and we appreciate how the patient will respond to full therapy. But we decide in advance, and this is in accord with the relatives, that after 3 days we will reevaluate. And if the patient is not improving after 3 days, then we will decide to give up. So there's this kind of trials could represent a way to admit a patient in the ICU when we are not so sure that this will be very beneficial for the patient. Again, we could continue and discuss it for much longer, but our time, I suppose, is limited.
Okay. I know and I believe there are more questions about that subject, because it is very important, and our guest is very strong in the subject. So please continue to ask the questions in break time. Now we have a second speaker instead of you. Please don't. There's no stage over there. So we have. Now, a reflection on 20 years of practice. David Kerr will tell us about that subject. Please go ahead.
Okay, everyone take a breath in. I'm not going to teach you anything clinical. That was clinical. This is not clinical. I want to start with just asking a question. How many people in the room have been practicing for less than 5 years? Put up your hand. You got to raise your hands high and tall. How many have been practicing for less than 10 years? How many of you have been practicing between 10 and 20 years? 20 and 30 years. The people in the front are starting to get embarrassed. 30 and 40 years. Has anyone here been practicing more than 40 years? Okay, so this is 20 years of my practice. This is year 20 for me, and I designed this talk to tell you what I've learned. The stories, the patients that have shaped my career, and this is not clinical, it's just what I've learned. And when I started working, I work in a large academic center in Toronto, Canada. Things were really easy. We didn't see patients in hallways. We used to get sleep on overnight shifts. And now we see patients in waiting rooms. And things have changed so much in the last 20 years. And when I was starting, about 10 years ago, I approached one of my colleagues and I said, Joel, things are getting bad. And he looked at me, he was older, he's probably about 80 years old now, and he said, David, until I'm dead, you're screwed. You're going to need to take care of this generation of baby boomers. And 10 years ago, Joel couldn't have been more correct. And I think whether you practice in Turkey, in India, in Singapore, in Canada, we are seeing this effect now. So what I want to do is to take you through my first shift to my last shift and to tell you what I've learned. So I remember my first shift. Does everyone remember their first time doing a night shift alone? Like totally. And I remember that shift so clearly because I was waiting for that last person to leave and thinking about how many hours I would be stuck by myself and hoping nothing bad would happen. And what was amazing was I was killing it. I was doing so well. It's 7 in the morning and my shift ends at 8 and there's no one to be seen. There's no one to hand over. And I have to say, I was feeling really good about myself. I knew I was good. I just didn't realize how good I was. And at 7:15, a patient was wheeled in, and I remember thinking to myself, crap, the board's not perfect, but you know, he's not going to be registered for till 7:30, 7:40. I don't really need to do anything. I can leave it for the morning guy. I said to the nurse, as I was just cleaning up some stuff, what's he here anyways? Is there anything wrong? Oh no, he was here last week with DKA. He's been vomiting. He's back. Don't worry about it. And I looked at him from the distance. I had no intention of seeing him. I was handing over a near perfect board. And then I get called to his room stat. Oh, crap, I don't really want to see another patient. I'm super tired. It's now 7:40. My shift ends at 8. And I go to see him, and he's unconscious. He's 21 years old. He's a type 1 diabetic. So what do you think? You have a 21-year-old who's difficult to rouse. What do you think? So I start to think maybe he's hypoglycemic. I can fix this in 20 minutes. What's his sugar? Oh, we don't have a sugar yet. Okay, well, do his sugar. Okay, I just sit there, just, you know, twiddling my thumbs, point of care sugar, and it says high. And I said, crap. And I said, check his pulse, and he's PA. So it's 2003, and I start CPR. And CPR in 2003 is different. I gave him all these amazing drugs. I got him into PA, and then he went into VF. I gave him amiodarone. I gave him lidocaine. I gave him magnesium. I gave him bertilium. Anyone remember that drug? I gave him procainamide. I put in a central line, a triple lumen catheter, because that's what we were doing. I intubated him. I put in an art line. I gave him some bicarb. I gave him some insulin. And 40 minutes later, he's still got no pulse. And I get his gas back. And he's hyperkalemic. And I give him some calcium, and I pronounced him dead. And I remember after that case, I felt gutted. How could I have not given calcium right out the gate. And I spoke to my friends, and they said, oh, Dave, you gave him beryllium, amiodarone, lidocaine, you intubated him, you did everything right. But in my mind, and I know what this guy looks like today, I know there's something I needed to do that I didn't do. And I learned that day two things. I learned that when I started practice, I used to be afraid of what walked in the door that would scare me. Throughout my journey, I've learned that the more important thing to get comfortable with is to get comfortable with those who walk out the door and not be afraid of them. But I also learned the most important lesson that day, and it's why I'm here today. If you want to save lives in the emergency department, teach. You don't save lives sewing up a drunk on a Saturday night. You save lives by teaching things that you missed, because you know others will go down that same pathway. And this was the first thing for me that had inspired me as an academic to want to make a difference, to say, you know what? I only used to think about calcium for dialysis patients. Maybe I should be more broad in who I give it to in an arrest state. The other thing I've learned in my 20 years is to listen. The average emergency physician will let a patient speak for 7 seconds before interrupting them. Are you average? I'm certainly below average. I'm more like a 3-second. And when the person starts with, in 1983, I developed this pain, and you're just like, just stop talking. We don't listen to people. And that's a challenge, and I want to talk to you about the art of listening. About 10 years ago, a 65-year-old man was brought into the emergency department by his 2 sons who were 18 years old, and they carried him to the waiting room from the car into a wheelchair, unresponsive. This was the family who didn't call an ambulance, despite the fact that their dad was GCS3 and unresponsive. These are rare birds. And here was his story. On Christmas Day, he had had a cardiac arrest. He suffered from hypoxic brain injury, and 3 months later, he went home. This was his first night at home. And he went to bed with his wife. At 7 in the morning, he was still sleeping. She went to make some tea. At 10 in the morning, she's still sleeping. At noon, he's still sleeping, and she starts to think, crap, like, I guess he's catching up for the 3 months of sleep he missed while in the hospital. At 2 o'clock, she decides, okay, he's been sleeping for 17 hours. I should go check on him. She can't wake him up. Imagine what she's been through. It's her first night with her husband in 3 months. And she brings him to our hospital. He comes to the triage, and I get called to see him stat by the best nurse in our hospital. You all know who she is, or he is, because you know when they're on how quickly you will run when they ask you to see someone. And I go see this person. I don't really know what's up, so I order a confusogram. You know what a confusogram is? Every single test you can think of. CBC, lights, creatinine, tox screen, thyroid, livers, urine, gas, lactate, CT head, extended lights, thyroid. It's all normal. The family doesn't want anything done. And the nurse, Ella, she walks over to me and she says, "What's wrong with the patient?" Ella, I have no idea. All his tests are normal. The family doesn't want anything done. She's quiet for a second, and then she looks at me and she says, "You know what's wrong with him? He's in status." I said, "What?" "He's in status. Why don't you give him something?" I said, "But he's not shaking. What do you mean he's in status?" She said, "Just give him something." "Why do you think he's in status?" "Well, when I triaged him, he was doing these funny things with his lips." "You have nothing to lose. Give him some midazolam." "Okay, you win, Ella. What am I going to say? Give him some midazolam. Here, give him 3 milligrams and 2 milligrams and, you know, keep her happy." So she gives 2 milligrams of midazolam. About 3 minutes later, she grabs my shirt and she says, "I want you to meet Mr. Johnston." He looks at me and he says, "Hello, doctor." And he was in non-convulsive status epilepticus. I had never seen it, I had never diagnosed it, and it's a big problem in people who've had hypoxic brain injury, of comatose patients in the ICU. This is incredibly common. But you need to listen to others. And listening to Ella was what is the reason that that guy was talking right away. And giving midazolam to patients right before I'm going to give them that intubation has bought me some people from avoiding plastic. Those people on neuroleptics, on antidepressants, history of seizures. Sometimes when I'm about to intubate them because their GCS is 3, I give them that midaz right before, and I wait a minute or two just to see if their LOC is from seizures that are non-convulsive. Do nurses ever ask you to come see them as a patient or to look after their family? Has that ever happened to you? The nurses in the department will say, "Hey, Dave, can you come see my loved one?" What I've learned in all these years of practice is the biggest compliment you can receive as a physician is when a nurse or colleague asks you to look after the person they love most. Don't get annoyed. Realize that this is the ultimate form of flattery when they want you to care for them. Every day we wake up, we have an opportunity to do some good, but there's so much bad that you have to navigate to get to the good. And this is Captain Chelsea Sullenberger, who landed his US Airways flight on the Hudson River in New York City. Sometimes we see a lot of crap, but there's inspiration in all the patients we see. Joe was a guy who came to our Emerge about 250 nights a year. Every single night, the chief complaint was the same: intoxication. I was doing a night shift about 10 years ago. I've seen Joe maybe 60 times in my career. And he walks in, his chief complaint, it was a little different. He had fallen and can't get up. Okay, it's 4 in the morning. He's not gonna go home till the morning anyways. I go see Joe, I heard you fell, you can't get up. Yeah, doctor, I can't feel my legs. So I go and I say, "Can you feel that?" "Yeah." "Can you feel that?" "Yeah." "Can you feel that?" "Yeah." "Okay, well listen, why don't you sober up and I'll come see you in the morning." And Joe said to me, "Doctor, I've been drunk every day of my life for the last 30 years. I'm not drunk." Oh, that's interesting. And Joe taught me an important lesson, that sometimes the neurological exam is not just a CT of the head. That my neuro exam was touch his legs, do a CT, he's fine. That sometimes you actually have to examine people. And I said, "You can't feel your legs, Joe?" He couldn't feel touch. So I took my fingers, "Do you feel that?" So he could feel touch. So I started with pain. No pain to about the belly button. So then I went to temperature, and he had a sensory level of pain and temperature loss from T10 down. And Joe, who had been drunk in our Emerge for 35 years, 60 nights a year, had an anterior cord syndrome. Just because I listened to someone, and just because I decided that sometimes you actually have to do an exam. It was very humbling. This past year, I picked up a chart. The chart was the next to be seen. 30-year-old female with a headache and 36 weeks pregnant. I'm going to say it again. 35-year-old female, headache, 36 weeks pregnant. When you pick up that chart, how much are you hoping that the person beside you picked up that chart instead? That's a tough one, right? I was like, crap, what did I do wrong? So I go see this woman. My first thought, okay, hypertension in a 35-year-old in her third trimester. What are you thinking about? Shout it out. Preeclampsia. Her pressure's 100/60. I thought maybe we could get it higher and then I could refer her to OB, but it wasn't high. And I was like, crap. So I ordered all the preeclampsia blood work. I went to talk to her. I was hoping that her pressure would be higher, because then I could just say she has preeclampsia, but it wasn't. All her blood work was normal. I do a real neuro exam because I sure as heck don't want to CT this woman. There's nothing to find. So I said to her, why are you here? You're 38 weeks pregnant, 36 weeks. Have you had preeclampsia? No. Are you sure you haven't had preeclampsia? No. So I said to her a question that sometimes I ask people, and sometimes it's snarky, but sometimes it's helpful. Do you come to hospitals often? She paused, and she had like a 2 out of 10 headache, occipital. And her husband says to me, doctor, can I say something? So polite. Polite people always have bad things happen to them. Of course. When my wife had an appendicitis, it perforated for 4 days before she came to the hospital. And you know how much that made me nervous. So I did a CT venogram and diagnosed a sagittal vein thrombosis that went all the way to her IVC. Sometimes you just have to ask people. She had a 2 out of 10 headache that got better with Tylenol. And the craziest thing about this case, and I don't know if you feel this way, but I feel that sometimes emergency medicine is what I ate for breakfast. Some days, for some reason, you connect with a patient and you understand them, or you see them and you can figure out that there may be something wrong, and you know in your mind that tomorrow you may not have figured that out. And that's the most humbling thing and frightening thing about our job, is I was so close to sending this woman home. I swear to God, 2 out of 10 headache, better with Tylenol, wanting to go home, but just something. And it's frightening because tomorrow I could have missed that. Nancy was a 74-year-old female. It was a Friday afternoon at 4 o'clock. I was just starting my shift. And the chief complaint said, tired and weak for 4 months, requesting a 4th opinion. Again, who's happy that they got stuck picking up that chart? 4th opinion. You can see the sarcasm in the nurse who wrote it from triage. So I pick it up. I have to go to the waiting room. Mrs. Smith? Mrs. Smith? So I start to think to myself, she must have left. The waits were long. I'm perfect. This is great. But in the distance, I see movement of an old person who looks like Mrs. Smith. I'm kind of hoping it's not her, but she's moving towards me. Crap. Mrs. Smith, come on. So we have a button on the wall that opens the door. I must have hit that button about 10 times before Mrs. Smith made it through the door. I swear I could have seen like 4 other patients. Eventually she comes here. After I've opened the door for her 10 times, I figure I'm going to bring her to the closest room possible so I can get rid of her short, because it took a long time, and this is a fourth opinion. So I go to talk to her and I say, you've been weak and you're sore all over and it's been 4 months? Yeah. And she can tell that I don't really care. Unfortunately, I'm grumpy. The rust and the cynicism has kind of acquired in my tenure. So I ask her all these questions. You saw this doctor and that doctor and this doctor and this person, and how can I help? So then I turn and I say to her, are you depressed? She pauses and she says to me, what year were you born? Okay, think about that. How are you feeling when she says that? Well, I get all defensive. Well, I don't think my birth has anything to do with you, so I'm not going to tell you my birth. Well, she says, I'm going to guess you're born in the 70s. Before you were born, I played tennis for Canada in Wimbledon. Oh, this is not her, that's Billie Jean King. I said, oh. She goes, and I look like looking at you, I'm in a lot better physical shape than you. I play tennis 2 sets, sometimes 3, every single day, 7 days a week, and all I want to do is be able to play tennis again. So you asked me if I'm depressed? I'm used to playing 4 sets of tennis a day, and now I can't even get out of bed in the morning. Of course I'm depressed. Does anyone know what's wrong with Mrs. Smith? I looked at her and I said, I'm going to order 1 blood test. And this blood test is going to change your life. Anyone? I can't hear well, but Mrs. Smith had an ESR of 120, and she had polymyalgia rheumatica. Now, this isn't the most exciting thing in your textbook. In fact, no one has ever in the history of a conference been invited to speak about PMR. But I'm going to tell you something. PMR, next to like a pulled elbow, is the best diagnosis you will make. There is no other diagnosis that will cause gratification. Now, every year, you know, my wife, she's an internal medicine specialist, and every year around the holidays, she gets chocolates, she gets champagne, she gets scarves, she gets tomato sauce. I get nothing. You get nothing. But Mrs. Smith used to buy me a box of chocolates from a really kind of borderline chocolate store in Toronto that your grandmother would have given you chocolates from when you were a little boy or a little girl. And every year, for 10 years, Mrs. Smith bought me chocolates at Christmas. Never saw her again. The only person who's ever bought me anything. About 4 years ago, the chocolates stopped. What's on your differential of chocolate stopped? She's dead. Nah, it happens. We're all gonna die. What can I do? During COVID, I went to see an old man. I walked in the room. He was there with his partner. Everyone's wearing masks and gowns and all that. And a woman says, hello, Dr. Carr, do you remember me? Again, a question I hate getting in the emergency department. Do you remember me? You know, with the mask and the gown, it's really hard to tell. She said, I played tennis in Wimbledon. I said, your ESR was 120. I've never forgot about you. Where the hell are my chocolates? I thought you were dead. And last year, the chocolates started coming back. Billy Mallon said, if you became an ER doc because you love thank yous, boy, did you fuck up. Because your best work does not know who you are. And in emergency medicine, it's very thankless what we do. It's very thankless. You make the diagnosis of an aortic dissection, the patient is going to think the surgeon is God. But you're God. And you have to realize that you need to celebrate yourself in this job. When you make that diagnosis, Go home, have a nice meal, buy yourself something special, do something fun that you wouldn't be, because no one celebrates you. Celebrate yourself. It's the only way to succeed and to survive in this business. So my interest clinically is hunting for zebras. I have spent my career looking for diagnoses that other people struggle to make. And people will say, Dave, you see all the cool cases. Okay? I want to tell you a story. A young woman comes in to me. The chief complaint is rash with their period. So, you know, I'm an emergency doctor, so rash during your period, I'm thinking she's got toxic shock, really cool, really excited to see her. But she says to me, yeah, I get this with my period every year for 18 months. Every month. So I said, well, you can't get toxic shock every month. You're no longer exciting to me. Every month you get a rash. Yeah. Can I see the rash? Oh, I don't have it anymore, doctor. So why are you here? Well, you know, every month for 18 months, I get a rash right before my period, and then I get my period and it goes away. And you don't have the rash now? Do you have a picture of it? No. But you're here anyways and you have no rash, just so I understand. Yeah. Okay. Do you care about this woman? Do you find her interesting? I see an honest reaction, which is a lot of us couldn't care less. She has no rash, her vitals are normal. This has been going on for almost 2 years. Why are you here? Now, Michael DeBakey would say, no physician can diagnose a condition she never thinks about. DeBakey never had the internet. So what I did, because I thought she was interesting, is I go to Google and I type in rash that occurs before menstruation. And it shows...
Mr. David, you have 2 more.
I'm going to go a bit longer.
Okay.
It shows that she has something called autoimmune progesterone dermatitis. Have any of you heard of this? No. So I walk in the room. I said, oh, sorry about that. You have classic APD. It's classic. Once you see it, you'll never miss it. Your options are either we take out your ovaries, but that seems drastic, or maybe you see your family doctor and go on the birth control pill. But it's classic. What the point of this story is if you want a fruitful academic career, you must be curious. If you're not curious, then you become average. You don't diagnose zebras. I had no idea what this condition was. I may never see it again. But by typing 4 words on Google, I was 100% confident I made that diagnosis. Wild. I leave you with one final case. This happened this summer. We had a lot of viral illnesses, and I got called to see an 8-year-old boy. He was wearing Spider-Man pajamas, and it was a febrile seizure. Is anyone nervous to see a febrile seizure? We got this. We see this pretty often. Temperature was 38.5. Apparently hasn't been well for 3 or 4 days. Parents brought him into the recess room, or to the room. He had had a seizure with EMS and another seizure. So I went to see him, getting a little bit of the story from the paramedics, getting a little bit of a story from the family, and all of a sudden, he has a cardiac arrest. I've run a lot of arrests in my career, but I can count in one hand, and not even all of it, the number of arrests I've run in children. And I can't count any of them that I've seen talking to me who've arrested. My brain was like mush. There are all these formulas you knew for ET tubes and chest tubes and medications. My brain was nowhere. I pulled out this Breslow tape and I ran this arrest. And, you know, with adults, we take so much pride We don't ask for help in cardiac arrest because they're kind of supposed to die if they're 90 and have a cardiac arrest. But the pediatrician came down. I was running this arrest, and she said, why don't we call the intensive care pediatrics at the other hospital? Because I didn't have pediatric ICU at my hospital. And they walked me through that arrest. And I did everything I could. And we did everything we could. And I knew where this was going. And I looked at the wall for something that I've done so many times in my career, and the parents were in the room, and I couldn't say the time of death. I couldn't say that number, and I still can't say that number. I didn't know what to say with these parents of this 8-year-old here. So I just kind of said, you know, I didn't say the number. I just said, okay, we can stop. I didn't know what to do. And then, you know, you haven't seen a patient for an hour and a half. Someone comes to you and says, I've had back pain I've been here for 9 hours and I've had back pain for 2 years, and somehow you have to smile and you have to pretend that that didn't affect you. And then a nurse says to you, Dave, our nurses are really upset about this situation. Do you think you could do a debrief? And it's as if we're supposed to be immune to this. Because we're doctors, we're not supposed to be affected by an 8-year-old boy who dies. But the nurses are. And I said, I'm the same as you. Hug your child. I don't know what else to say. Everyone did well. Life is very short. It's very tragic. You will never forget this kid. I can think about every kid I've lost. I know all their faces. It's just what we do. And how do we get through 20 years, 40 years? Is you need to have a team of support. Sarah Gray, who's the one who is in the front, came up with this concept of having failure friends. You need to know people in your group that you can call when life's crappy. And you might need a failure friend for your marriage. You might need a failure friend for your divorce, for raising children. I have so many failure friends. And you need a failure friend for when that patient didn't turn out the way you wanted to, and you feel gutted and you feel crap. How many of you have a mentor? How many of you are a mentor? Good. These are my 2 mentors. This year, they both retired. I feel like an orphan. I've lost the 2 people. And I remember saying to Anil once, I said to him, how can I thank you for what you've done to help my career? You know, I was trying to see, does he drink? Does he like chocolates? Does he like golf? And he said to me, David, one day you will be in the same situation as me. And what I would ask is you give back to that resident, to that staff, and then you will pay me back. Pay it forward. We've all had wonderful mentors that have pushed us forward. The greatest compliment to them is to emulate them and to give back to those who are the future of your profession in your country. So what can I say to wrap up this unbelievable conference and this unbelievable day at WASM? If you want to save lives, teach. You learn things at conferences, bring them home. Teach to your environment. You will make a difference. You have to learn to listen. We have 2 ears and 1 mouth, which means we're supposed to listen twice as much as we talk. Listen to patients. Probably more importantly, listen to nurses. Be curious. If you want to be an average doc, you're already there. If you want to be a great doc, be curious and push the envelope. And if you're not a mentor, seek mentorship and be a mentor. And thank you very much for your time.
Thank you so much, Mr. Kerr. And they were, all the slides almost, were very nice reflections about life.
It looks like there's a big party tonight,
Do you want-
a big gala. Right here, 2015. What's the dress code, Bashar? Do we have to dress up nice? A tuxedo? Everyone come celebrate tonight, 10:15, 8:15, and we'll see you all later.
Thank you.